السلام عليكم. هنتكلم النهاردة we will be talking about relapse and retention in orthodontics. To start, we need to discuss why retention in orthodontics is necessary. The first reason retention in orthodontics is necessary is because the gingival and periodontal tissues are always affected by orthodontic tooth movement and causes disorganization of the periodontal ligament. And during the process of reorganization, we need time. The periodontal ligament needs time to reorganize itself without the presence of the orthodontic appliance. So, if we don't do any retention, then relapse would be inevitable due to the periodontal ligament is disorganized. So the periodontal ligament needs time to be reorganized. Also, if it happened that we put the teeth in an unstable position after the treatment, the soft tissue applies pressure constantly on the teeth that has been moved, and that produce relapse tendency. In addition to the changes that has been produced by growth, if the patient is already a class 2 or class 3 patient, skeletal malocclusion, and you already corrected this type of malocclusion, if the patient still have any potential of growth, then this potential will convert that corrected case into a continuation of the skeletal abnormality. So, in order to summarize the above, the following must be considered. First, the gingival and periodontal tissues are affected by orthodontic tooth movement and require time for reorganization when the appliance is removed, and also moving the teeth to an unstable position. It produces a constant pressure from the surrounding musculature, as well as the changes produced by growth that can alter the orthodontic treatment and causes relapse and recurrence of the skeletal condition. We have to recognize the role of periodontal tissue in relapse. Like we said before, that orthodontic treatment causes disorganization of the periodontal ligament and widening of the periodontal ligament space and disruption of collagen fiber bundles that supports each tooth, and these are normal responses to the orthodontic tooth movement. And in order to correct that, we need to restore the normal architecture of the PDL by means of reorganization and restoration of the periodontal ligament, and that takes at least 3 to 4 months. And it can be extended also to 6 months. However, the collagenous or elastic fibers contained in the gingival fibers take about 1 year to reorganize. So, one may ask, for how long retention should take place? If we take it reason by reason, then we have to understand that for the first reason, the periodontal ligament, the essential fibers, needs 3 to 4 months and can be extended to another 6 months. So we need to put the retainer full time for at least 6 months in order for the principal collagenous fibers to reorganize. And that should be followed by part-time wearing of the appliance for at least another 12 months to allow time for remodeling and reorganization of the gingival elastic fibers that takes up to 1 year to reorganize. But if you inherently put the teeth in an abnormal position, then this patient must put the retention or must use a retainer for a lifetime. And regarding skeletal retention, then we put the initial appliances that has been used in skeletal correction part-time during night time for at least until all the growth potential has been seized and stopped and no more growth potential in that patient is recognized anymore. So, why relapse may occur, or how come a relapse case and retention has been lost after orthodontic tooth movement? Due to the following. First, corrected overbites and overjets tend to relapse. The closed spaces like diastemas tends to reopen. A severely rotated teeth, when you tend to correct it and derotate it, it tends to rotate again. Expanded arches tends to collapse again. And the causes are periodontal ligament has not reached its full reorganized stage, and it has continued in the disorganized state. Also, like we said before, the abnormal pressure from musculature due to teeth has been moved to an unstable position, and a retainer has not been inserted for lifetime. And if the patient had a minor trauma due to abnormal pressure habit that he or she has not stopped using the correct pressure, the correct habit breaker appliance, also, like we said before, a remaining growth pattern has occurred unfavorable for the treated case. Example, the skeletal conditions that needed retention until the potential of growth ceases. We have special cases for retention in orthodontics. Like, for example, in class 2 patients. In class 2 patients, you correct the class 2 skeletal condition using either a headgear or a functional appliance or a combination between the two. Well, for class 2 patients, we recommend for retention that in the morning during daytime you use your regular Hany retainer, and then during nighttime you use your headgear or your functional appliance or a combination between the two according to the case for nighttime only. And you continue using that until no more growth is realized. For class 3 patients, you have to understand that class 3 is the most critical condition for retention in class 3. And we usually give the patient a chin-cup appliance to use it during night time, but however during the daytime we prefer using the Hany retainer if an orthodontic treatment has been combined with the skeletal treatment with this patient. However, we have to understand that if skeletal class 3 has been realized to be or diagnosed to be severe from the beginning, then this patient most probably will have to go through surgery, orthodontic surgery, after the growth has been stopped, because severe class 3 is very, very, very difficult to retain, and usually it relapses easily. Also, if you have a severely rotated tooth, then we have two things we can do to derotate that tooth. The first treatment modality is to overcorrect the severely rotated tooth, so that when relapse occurs, the slight relapse put the tooth in its proper position. The second option we have to retain the derotated tooth is a simple surgical procedure called the supracrestal fibrotomy, which is a famous procedure to control the relapse of the derotated teeth. Also, if you have a deep overbite case, then it is recommended that you use a posterior bite plane occlusal to the posterior teeth so that you prevent further eruption of the posterior teeth if you have an anterior open bite, and if you have corrected regarding the types of retainers used in orthodontics. We usually have the Hany retainer, which is the most famous retainer in orthodontic treatment, and it is quite effective in retention for the first 6 months and the year after. That for a regular case of orthodontics. However, if you put the teeth into an unstable position, then we said before that we need to put retainer lifetime, and therefore we prefer to use the fixed retainer, and usually we put it in the lower anterior teeth on the lingual side. Sometimes also we can use the clear retainer, but it is recommended to use the clear retainer after the initial use of the hard retainer for the first 6 months. Then you can replace it with the clear retainer for the rest of the retention time.